and welcome once again to another episode of Conversations with the Chamber. My name is John Smolensky. I'm the Executive Director of the Lynnfield Chamber of Commerce. And alongside me today is our co-host, Carly Fortier, who's going to be with us today as we do another interview and another interesting program to provide you some insight and useful background information of another segment of our local industry here in Wakefield. The focus of our show, Conversations with the Chamber, is to provide you, our viewer, an insight and a look behind the scenes of what happens to our local businesses or what has happened to our local businesses in the period of the COVID pandemic. We all know what these businesses were like prior to the introduction of COVID and what that's done to our society. But how have these businesses pivoted? How have they succeeded in continuing to serve their customers, to serve their base, keep their businesses alive, and continue to provide the services that are very much necessary in our local economy around us here in the Wakefield-Lynnfield area? So we're very happy to have them today, and we're going to do our best to ask the questions that will give you that insight and the opportunity to learn a little bit more about how they function that you might not have learned before. And we're very happy to welcome here with us this morning two local businesses, representatives of a very important industry here in the medical health area of Wakefield, and that's physical therapy. And we're very happy to welcome from right here in Wakefield, Ed Harding from HD Physical Therapy, offices here in Wakefield at Lakeside Office Park and in Burlington. And we're also very happy to welcome with us here today, Katie Wadland of the Healthy Aging Physical Therapy Service Company. Now, both of these individuals share some commonalities, but then again, there are some huge differences. Ed is more of a traditional, as we know it, physical therapy office that we visit and on a regular basis are able to accommodate our physical needs with his help and instruction. But Katie's a little different, and I'm not going to give you too much insight into Katie, but she has a unique way of servicing people's physical therapy needs in a non-traditional fashion as compared to what we've seen with Ed. So what I'm going to do is give each of these individuals an opportunity to give you a brief overview of what part of the industry they represent in physical therapy and a little background of their experience, how long they've been in business, and how they like to provide these services to us before we get into the in-depth questions of COVID related. So with that, Ed, being the more traditional, well-known part of the industry as far as an office, physical therapy, physical therapists on site, scheduling appointments, working with hospitals and doctors. Give us a little idea about HD Physical Therapy, where you work, how many years of experience you had, and a little bit about your part of the industry as you've seen it prior to COVID, if you will.
Yeah, sure. We've been in Wakefield now for about 9 years. Opened the practice in 2012 at the Lakeside Office Park. We really got involved in the community right away between the chamber and Rotarian and the whole bit. From there, we have a 3,000 square foot facility. We do a lot of, patients come in on the half hour to the hour, depending on what their kind of needs are. They come in, they meet with a therapist. We do a lot of manual hands-on skills. We run them through some exercise. There's a lot of different variations of physical therapy, and it's a very broad umbrella from what we might need, from a patient's perspective. But from that side, you come in for your typical appointment. I think pre-COVID, you're probably a little bit close interaction with a lot of people because there's a lot of people in the, within the square foot. It's more like an open box. So when you come in, you sit down, there's a lot of other people that are kind of within that, close proximity to you, which obviously we had to change a little bit once the COVID scenario kind of hit. So, and it's been great. I mean, we help a ton of people in the community. It's been a great impact that way, and we've just enjoyed being part of this area for as long as we have. So
now, when we talk physical therapy, you're of course talking muscular and skeletal therapy, working arms or legs or hips or whatever it might be that the individual needs. Do you have equipment in the office as part of this that you use on an everyday basis?
We do.
Again?
Yeah, so there's different components of PT. From what we take it, I mean, I'm hoping not to always see someone once they're, already injured. I'm kind of hoping to do some preventative care as well that way. I think that's the way the profession's trying to hopefully go to. Now that, in our profession, it's moved to the fact that the PTs now, it's required to be a doctorate program. So it used to be a bachelor's degree, which has progressed through the years to be a doctorate program, which allows us more direct access to patients. So, we're trying to be a little bit more of that helpful cornerstone to where, you don't have to go see your doctor first. You can come in to see your physical therapist if it is a musculoskeletal injury. If you have some knee or back pain that's going on, you can come see us and at least get some professional advice, to be able to kind of guide you along that path without having to necessarily take some of the other steps, to go see your doctor first. And then, to be able to do that, you have to, be covered by all insurance companies and various different things along those lines. So, yeah, and then, once you get in, we do have various different equipment depending on where you're at in your stage of therapy. So we do a lot of manual therapies, but to your point, we have treadmills and bikes and various different ways to kind of, have some fun while you're doing that therapy as well. So.
All right, so here you are in a 3,000 square foot box, as you pretty much described it.
Yep.
All right, and the traditional front door entrance, waiting room. In you come, get your appointment, sit in the waiting room, and then you wait your turn, and off you go into a particular part of this 3,000 square foot box.
Absolutely.
For your therapy.
Yep.
All right, so with that in mind, let's move to the contrasting
Sure.
way of doing this, and that would be over to you, Katie.
Sure.
So here he is in his 3,000 square foot office.
Don't make me jealous, I know.
And he has the receptionist and the therapist.
Yep, the back,
and
the-
all
yep.
the bells and whistles that go along with it, as we all would come to expect in physical therapy. Yet here you are providing almost the same type of services.
Yep.
With a little bit of a handicap in that you don't have a 3,000 square foot office, you don't have a receptionist with you, you don't have a treadmill in the back seat of your car, you don't have anything.
I do have a bike, for the record. It's a little smaller.
So why don't you start out with describing for our viewers exactly what type of PT you're providing, or describe the industry, the segment of the industry that you now represent versus the traditional, if
Sure.
you will, please.
Yeah, I think the easiest way to explain what I do is actually sort of backing up a little bit and talk about what I did do prior to this. So I actually started as an outpatient therapist like Ed. I worked more in the neuro segment, so I saw people at Spalding Rehab and Braintree Rehab for years that had spinal cord injuries and strokes and brain injuries. So that's kind of where I started my career. 16 years ago, something like that. And I worked there for about 5 years, and I actually transitioned to home health 7 years ago. I used to work for the VNA in Middlesex East right here in town, also at Lakeside. We were neighbors before we were working together here. And I did that for about 7 years. I worked they merged with Leahy, so I've actually been the Wakefield-based Leahy Health at Home physical therapist for some time now. So I'm no stranger to treating folks in Wakefield, just from a different avenue. And I worked there through the spring in the middle of all the COVID craziness. And I ended up taking a leave when the kids went home for remote school. I had switched my hours to be Wednesday and weekends, and I was homeschooling the other days, and it was just a lot. So when it came down to it, I took a leave for about 14 weeks to be home with the girls, my 2 girls. And when it came to decide what to do, I ended up leaving that job and decided to open my own practice.
That's mobile PT is what you're referring to as your own practice?
Yeah, so my own practice is called Healthy Aging Physical Therapy. So what we were struggling with as home health therapists during COVID, I'm kind of jumping ahead to some of the pivot stuff, is that we couldn't discharge our patients because a lot of the clinics at this point they had the forced closures. So traditionally we'll see someone in home health after they're home from a hospital or when they have a knee replacement or they have a stroke. And then we see them until they're really able to get out back in the community. And then I'd send them to Ed or Glenn. So we've known each other for years, and he would know about Katie, the home health PT, because the patients would come in and say I had Katie. So that was the traditional model. But when all the clinics closed and a lot of the folks didn't feel safe going out anymore, we really were stuck in a bit of a lurch because we couldn't discharge the patients. They were still coming in from the hospitals. And it was really challenging trying to figure out how to deal with this in the middle of all the face shields and all the equipment and everything. So I opened up my practice to really service the needs of the folks that were kind of stuck at home at this point. And traditionally, there's a lot of people also who get discharged from home health, but still struggle to get to outpatient clinics, whether they don't drive, they need to ask for rides, whether they are at fall risk, or whether they have some immunocompromised situations where it's not safe to be out in the public. So I opened my practice, Healthy Aging, and I see people in their homes, but I'm actually an outpatient therapist, just like Ed. So I accept Medicare Part B, I accept Blue Cross Blue Shield, and I also take Medicare Advantage plans. So I can treat just like I would in an outpatient clinic, but I can see you in your home. So you asked about equipment. I actually have a Honda Pilot. It's a white Honda Pilot with my name on the side, if you ever see me wave in town, but my trunk is full of equipment, so I actually sort of bring the clinic to you. Not quite as big. I don't have the 3,000 square feet, but I'm always lugging in steps and bicycles and balance equipment, and I keep it pretty interesting that way.
All right, so we have Ed sitting in his comfortable office with his chair and everyone around him as he directs traffic, more or less.
Yep.
And you are the traffic as you're running up and down the streets in your Honda Pilot.
I do.
Visiting people while Ed sits back sucking his iced coffee in the office. So,
Yeah.
did I have the picture correctly?
Exactly. The one thing I miss about pre-COVID life is having my coffee in the morning with patients, and now I can't, and it drives me crazy. So my coffee stays in the car, but someday I'll bring it back to the
All right,
morning
so
routine.
we have our table set. We have our traditional and
Yep.
we have our non-traditional. Now, we know how things were working in the perfect world, if you will, before COVID. Ed, how do you take a 3,000 square foot office with multiple employees, with multiple offices, with everything that you have in an orderly system? Because
Yeah.
obviously you're representative of a growing industry and a need as people recognize the value of therapy today more than ever.
Sure.
Your techniques are advanced from what little I know. So how do you take that? And Kali is one that's educated me on this and told me, John, the word for this is not how they turned it around, not how did they adapt. The word is, Kali?
Pivot.
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 So how did you pivot your business from one day, everything you knew after all those years in business, to the next day, it's gone and taken away from you? What changed within your industry? How do you continue to serve those people that, as we've already noted, still are coming out of the hospital, still have these problems
Sure.
and need these services? So what did you do?
Yeah, I think in a few ways there were some, initial challenges there that, we were, faced to make some pretty, interesting decisions. So, initially I think the biggest decision to make was do you stay open or do you close? I think was probably our biggest thought process, right? So, there's flip sides to both sides of that equation, right? So am I putting my patients and my staff at risk by staying open? Or are we really being there to kind of help the patients because of the fact that there were other offices that had closed, doctors' offices that were closed, you weren't able to, get in to see people? And a big component of what we do is we treat some patients that are in some severe pain, like debilitating, can't move, type of injuries. So from that side, I think, and then you have the other side where it's like, if I stay open though, I have to essentially pay my staff and do this, but if we don't have the business to support what we're doing, it's a really delicate balance in there to try to figure out what's going on. From one component, as therapists, we're trained in infectious disease. So when you're talking about sanitization and cleaning tables and putting gloves on, maybe we weren't wearing masks and shields in HDPT previous to this, but it's not out of the norm for us to understand in our profession, you do have infectious disease that goes on and you do have to take those precautions. And that's nothing that I would say was other than the price of gloves going through the roof. That was definitely kind of a change and a tweak that way for us to do. But things like adjusting our schedule now, because when you have 7 to 8 therapists that are running full time on the floor, we can't have that many people in the clinic at the same time. We didn't offer telehealth, previous to that. You'd heard about it, but I'm not even sure the technology was all that, great at that point yet for me to meet with the patient, at a distance to be able to do it. And the fact that now you have to train your whole staff on even getting into that scenario, because even though they offer it, it's nothing we had practiced before. I'm not used to, looking at a video camera and assessing, what type of pain and where it's coming from. And, and then we, all the internet issues, some of our patients couldn't figure out how to get on, and having multiple platforms. At one point I had, I think, 4 telehealth platforms, just because of the fact that some patients with their internet connection can get on the Google Meet versus the Zoom, but not on the Zoom, on the Doxy.me, and maybe not on Doxy.me, but through our, our software system. So, and then it really became quite a challenge that way to try to figure that out.
So just to stop you for a second, to build on this, as this hit and you're trying to pivot the business itself, you have to pull back and actually retrain yourself and your staff as to how you're going to go move forward, because this is hands-on business, literally.
Absolutely, yes.
And so before you can even begin to bring in patients to evaluate their needs, you have to reevaluate how exactly you're going to assess those needs and retrain your staff, right?
Right, yes. And within the matter of, it's not like you knew this was coming and we had 2 weeks to prepare.
Right.
And we can figure some of that out. You get right into this, and you get right into it immediately, and you have to, I had to educate myself before I can start educating the rest of the team on what we're going to do that way.
So now I would think I'm not aware of how much you have in the way of staff. Again, a little different from what Katie's got to deal with, but you have to worry about training the staff. Also now their physical well-being and health,
Absolutely.
in addition to the patients that are coming in.
Yes.
So that's a pretty hefty burden. I mean, you think you're not only a traffic cop that we talked about originally with yourself, but now you're your own little health agent.
Right.
What can I do to protect my staff? What can I do to protect my patients? How do I protect my business?
Right.
It's an accumulative thing. So that was quite a challenge. And I believe your partner's Glenn down there. And
Yes.
you and Glenn work together on this and develop an outline of a strategy of how you're going to move this forward?
Yeah, we did. I mean, obviously, and I think, initially when, and look, I mean, I think the government, the state, the national government, we're all learning as it was going along a little bit. So, there were a lot of rules and regs that were set in place where it was difficult to find where we fit into that part of that umbrella, right? Are we the place that needs to shut down? Mm-hmm. We are essential, but even though we're essential, it didn't necessarily state like outpatient physical therapy, but we are healthcare. So there was a lot of trying to decipher the code as to like, what is the most appropriate step? Because again, I don't want to put anyone at risk, both staff and patients, but I want to be there as a resource for patients, especially if they have nowhere else to go. And I can be the one in the community that can help through that scenario. We were helping in ways that maybe we weren't, traditionally used to in the past that way. So, I mean, that was just definitely, an interesting process.
So you
there.
continue to have people into the office, but on a more regulated, sparse?
Yeah, so, I mean, we're definitely within we were within that space that you're not supposed to be the entire time. If you're in the clinic, it's because you need my hands on you and you need me stretching you and moving you. If you are beyond that and you're more end stage rehab, right, and you are more exercise driven, which we do get some patients like that, those are the patients that were easier to transition to telehealth. But if you're in a lot of pain,
you could give them like homework.
You got it. Yes.
Right.
Yep. And that was fine. And even then, like, how much of that do I need to stand there and watch you do and make corrections? And it's tough that way. But yeah, I mean, that was probably the most difficult part about the fact that my services required us to be within the 6 foot distance. If you're in the office, that's where. And then I don't have like private rooms. Like I have 2 private rooms, but we have a big open area. So then on top of that, it's like if there's 3 of us treating a patient, now there's just that much more exposure. So we had to be careful on, how we schedule and who takes a lunch. And, I mean, we went from, I mean, at the end of the day, we're treating like, 400 people a week to like, 120. So it was like down to like barely anything. And then, how you, staff on and staff off and not exposing people. And Glenn and I separated, and I went to the Burlington office. He stayed in the Wakefield office to try to just, create even more of that separation.
Did you feel that were the numbers lower? I mean, obviously because you had to make the schedules that way, but was it easier because people were kind of dropping off because they were nervous? Because I do know, just based on my personal experience, my husband's experience, physical therapy is hands-on.
Yeah.
So now I'm sure it's like now a trickle-down effect. People are now worse off than they were, and they're trying to get back in.
Absolutely.
Right.
I mean, and then, on top of worse off, I mean, we had patients that contracted COVID throughout the scenario, and that pivoted a little bit about what we were doing that way
So
as
you
well.
had to decide who was at risk enough to come in and who was not.
Yes.
So I'm sure there were people that were unhappy with your decision.
Yeah.
If they wanted to have their
Yeah.
physical therapy continue, you had to deny them.
On both sides, right? I mean, the nice part about what had happened, at least, from our perspective, is our profession. There were a lot of, other colleagues that were also trying to march together and created some Facebook pages. And around the state, we were sharing with each other, like, hey, what are you doing? Because none of us wanted to be the only person just marching to the beat of their own drum, but we all wanted to make sure that none of us were doing anything too out of the norm.
Industry.
So, as an industry overall. And,
That's good.
thankfully we all, had a resource for us to be able to communicate, that allowed us to develop like some, decent norms that way to try to figure out, how do you offer services yet not put anyone at risk. And then there was still this unknown of like, oh my goodness, like, should I be treating you? Because if you come to the clinic and you catch COVID because of me, I'm going to feel awful, but you also can't get out of bed. Like, you can't move. So where's that? It was difficult to try to find that.
A lot of
happy medium.
prioritizing for people, for sure.
So here you are, again, being that traffic cop, for the lack of a better word, controlling who's coming in and trying to manage that as best as possible so the risk is relatively low.
Yep.
And you're managing that. Now, on the other side of the coin, here's Katie walking headlong, head first into who knows what type of situation.
Absolutely.
Going into a person's home as you deliver this mobile physical therapy. So, Katie, that had to be a little stressful for you. I mean, you mentioned you have children. You mentioned you had dropped from the position you were in to take a leave. And what in the world just made you decide, hey, it's COVID. I'm going to walk into people's house. Hey, let me come work on you and do this. I mean, that took a leap of faith that you felt. I mean, delivering the service is commendable. It's admirable that you knew there was still a need. But you got to think most people are doing everything they can to run in the other direction. And here you are walking headlong first, one-on-one into people's homes, not knowing what was going on. What were you thinking?
You know, I had been doing it all along for home health. There wasn't choices. You know, people had to be seen when I worked for Leahy, and it was just the way it was. So I'd already been in that kind of position and already trained.
Weren't you hesitant, Katie, knowing that you weren't sure what was on the other side of that front door when you went in?
Yeah, but that's home health in general. That's just the story how it always goes. You never know what's on the other side of the door. But yes, it was definitely scary. We weren't vaccinated. We were taking the precautions that we had that day from whatever upper, chain management that we were given. But, what we do is very medical. And we really saw it in home health as we were helping people stay out of the hospital. And that was the most important thing back then, was trying to manage things in the community so we didn't overload the hospitals because they were already overloaded with the COVID. So if I could do my part in keeping someone healthy at home and managing things differently, which that was a pivot in home health in general, is we were doing more triaging for the doctors a lot of the time. If someone had symptoms of, say, CHF or heart failure, instead of sending them into their doctor, which weren't seeing patients if they had a cough, or to the ER to be assessed, we were doing a lot of the triaging at home and calling things in and trying to manage. Because that was really, if you remember, that was the big deal, is the hospitals were full capacity. So what could we do from our end? So I like to help, right? I'm a helper. I don't understand, I couldn't sit home. It actually drove me crazy. We had a lot of discussions, my husband and I. He would have been very happy for me to stay home this entire time. I was trying to volunteer for things right and left to go do COVID testing sites, and he was like, no, putting my foot down. So this was a good compromise. It's something I was comfortable. It's a skill I could use that I have developed over years. And I had to do something and do my part and also make a living. That's part of it too. So I guess my pivot wasn't so much changing what I was already doing. It was creating a whole nother system, because the therapy is easy. I was an outpatient therapist. I've been home health. I just combined the two to basically be an outpatient therapist at home. But the business side was totally new to me. I have zero business background, zero. So I had to literally figure out, how do I make an LLC? How do I do taxes? And now I have an employee. How do I get an employee if I need somebody? How do I insure myself? So all that I did during that 14 weeks when I was home with my kids. I established a business. And then by August, I was up and running. And, the same thing. I had to figure out the CDC protocols and go with the flow and make changes and start with as much protection as I could. And then when it got a little safer, when I got vaccinated, start to wean down some layers. So now I'm down to just the mask, which is amazing. It's like working in heaven compared to what we were working in. And try to keep my patients safe. I feel the pressure a little bit. I'm going home to home. I would never want to have to call someone and say I exposed you to COVID. So I think that was the hardest thing for me sort of personally, was trying to figure out how to keep my patients safe as I traveled throughout my day and just being responsible that way.
Now, I would think, again, a little bit unlike my friend over here, Ed, that some of the people you're visiting might be homebound. So you might be the only contact they had with an outside world. So not only are you a physical therapist, you're more of a social therapist as well, providing them insight and contact with other people, which adds additional stress. So now they're looking at you as not just my person coming in for my PT.
Yep.
This is my person coming in who's a contact with what's going on outside the outside world that I don't have. So that has to develop some sort of bonds with these people that makes you even more concerned about making sure that you're adhering to the guidelines and doing what's necessary.
Exactly. And, part of the nice thing about having my own practice now is I can treat the way I want to treat. And I've always been more holistic in my approach. And I really care about my patients' well-beings all around. So I feel like that's sort of par for my course normally is, I'm not just seeing them for their whatever impairment they might have or diagnosis they might have, but I'm also making referrals and phone calls and trying to help them figure out safety measures and help, talking to their caregivers about how to help them. So that's sort of my practice mentality in general. So that part is part of who I am as a therapist.
I think that's an important part of both of your businesses is the interaction that you build with the customer, or I would say a customer, a client, but what actually becomes almost a friend in many ways. Is I'm sure they talk about family, and as you get to understand their physical needs, it's you go in their mental needs as well.
Oh yeah,
sure.
What that stress might be. So here we are. You're traveling through in a vehicle, your Honda. Is it a Honda again?
My Honda Pilot.
Okay, you get your Honda Pilot. You're out there visiting. You're stationary in a simple location. How do you two work together? How does that synergy takes place? How does, I don't know, does she go to you or do you go to her, or is it go in both directions? So one of you can take the lead on this, because I'm just curious. You have two different models of providing the same kind of service, but the similarities end in many cases. Now, how do you get these differences to work together?
Yeah, I mean, not to be too long-winded on that, because I don't want to be. There are a lot of ways that we work with each other and can help each other tremendously, right? I mean, to try to break it down pretty simply, I mean, the barrier to us from her angle is you do have to get to us, right? That is, I mean, I'm not traveling my facility to your home, right? I'm there. So if you have an issue getting there, if you have an issue around your house, if there's something, because sometimes we do exercises at PT in my clinic that are great because I have pieces of equipment, but at the end of the day, sometimes the best way for you to be able to function is like how you function on a daily basis within your environment, and that is sometimes the best resource for you, right? So many times she's getting people able to come to an outpatient PT, and not to like narrow down what she does or what I do too much, right? But then other times, you've reached that kind of like medical necessity plateau for you to come into HDPT, but there's still some things that you need to kind of master at home to make you safe, and I don't want to speak too much on her, but that's how we would end up referring to, and that's how we do refer to her, right? Is I have patients that, right now I know a couple patients I have referred directly to us because they're not able to get out of the house. It's not safe for them to get in the vehicle. It's not safe for them to get in and out of the facility. Maybe once they're there, I could do some stuff with them, but that commute is very difficult for them. So that's how that comes into play for us with her.
So you might have someone calling for a service, then you find out and identify you can't meet their need now, and she'll pick up the slack and sort of segue them back to you, and she may have someone that comes to her immediately and she could pass it along to you. Is that fair to say, Kate?
Yeah, so I've been so happy with how collaborative I've been with, Glenn and Ed, and also Kelly over at AMPT. When I first opened my practice, I went into each of them and I said, can I please just tell you what I'm doing? I laid out my grand scheme here, and I really presented it as a collaboration because it's not competitive. We have a different niche. I'm not a manual orthopedic therapist. I'm not the person to see. Like, I can help you with some orthopedic issues, of course, but if I have someone who's better off, with their hands on with someone in the clinic, I send them in. And just like Ed said, I get a lot of referrals for patients' mothers and patients' fathers. They say, oh, in conversation, so-and-so mentioned that mom's struggling at home. Could you go see them? And it's a back and forth. And I know I've always referred to them, so I really refer to places I trust. I don't want to send someone somewhere I don't trust the care. I have been a patient there, so I feel like I hands-on, I understand the benefit of being seen in the clinic. And I think PTs in general are a pretty unique crew. Like, we're all very collaborative, and I have not faced any like competitive pushes from other therapists. It's really been, how can we help each other? And there's not any financial benefit. There's not any like connection that way. It's just, we're caregivers. Like, we want to help people. So if I can help someone better than Ed can, I see them. And if Ed can help someone better than I can, then he sees them. It's just that simple. It's just really, really collaborative.
Wow.
Well, it's working for the benefit of many, and not just the benefit of a particular specific group, because you go from young adults all the way up to the elderly, I imagine, the seniors. So the need is there, and it's actually refreshing to find out that that type of collaboration has grown and continues to grow. An important part I'd like to go back to the very beginning, which I believe you mentioned, Katie, and Ed probably is in the same situation. your services are medically covered by most insurances. Is that correct? Because whether it's in-home, such as yourself, Katie, or yours, Ed, are there
Right.
any medical restrictions that would prevent people from taking advantage of these services if they're in need? Some insight as to, all right, someone has something like this, who would they call first?
Sure.
And
So everyone
how
has
they
their
go
own
about that?
like business philosophy, purpose, intention, right? When we opened HD, our intention was to be able to help the community on any level. And I want everyone to feel good that if you need some type of therapy services and you're unsure, that you can come into my four walls. And we offer same day appointments, so I can get you in within a day or two to be seen. And the reason why I do that is because I want to be a resource for the community to do that. But the flip side of that is I have to be a provider for all insurance companies, right? And there are benefits to that and not so many benefits to that, right? Not all insurance companies
I
are good to
bet.
deal with. Not all of them pay a lot. I mean, some of them make you jump through 25 hoops to get there and, really restrict what you do. But for me to stand out on the, in the chamber, in the Rotary and do that and say, hey, look, if you need help, I'm here to help. I have to be able to, from HD's perspective, we need to be able to offer that. So we do take, advantage of our direct access within the state, and we're providers for all insurance companies, whether it's the not so fun one, the really fun one, doesn't really matter. So we do that, but that's kind of our treatment model. That's what I want, from a perspective. And I want anyone to know that no matter what, you can come in, and even if I can't help you, I can refer you to where you need to be. I can help you get to your doctor, whatever you need to do, across the board. But the flip side to that, in our opinion, is we need to be able to be providers for all insurance companies, so you don't have any obstacle into coming into the four walls. So
No, Katie, just the opposite. You just started your own business, so you had to go through a process of validation to actually become, I guess, for lack of a better word, accredited. So insurance companies would recognize you as a valid business.
Yeah.
And allow you to accept their insurances or actually provide the invoices for them to pay. So
Right.
that had to be a learning curve for you. And how do you educate people to let them know, I can come to you and I can provide similar services to Ed, and I can still accept your insurance? That's got to be an important part of your model.
It is, and again, like you said, it's totally new to me. So the credentialing with Medicare was the most important step for me, as I see a geriatric population, primarily older adults. So that was the first step, and just figuring out as I go how to deal with the insurances and the authorizations and all that. Basically, the easiest thing for people to do is just call and ask. If you have an insurance I don't credential with, then I would refer out, or I would try to figure out if you have out-of-network benefits. Generally speaking, if you're, older adult, you have either Medicare or an Advantage plan. That's pretty common. I take most of them. So it's pretty simple and straightforward. And in terms of, like you mentioned, barriers to care, I think that people don't always understand what their Medicare benefit provides them. Basically, as long as we can show that your care is medically necessary and skilled and reasonable, those are kind of the big terms, then we can have Medicare Part B cover your care. Medicare Part B covers outpatient therapy. Medicare Part A covers inpatient, and it covers home health. So they're two different categories.
Interesting.
So most folks have Medicare B. And then Medicare Part C are those Advantage plans. Some people pay for having like Tufts or AARP or UHC manage their Medicare programs. So, either way, a lot's changed in the last 15 years since I've been a therapist, but they no longer have a Medicare cap. People are sometimes familiar with a Medicare cap, where you can't treat more than a certain number of visits, and they've changed the way they do things. Basically, it's up to our clinical judgment. If I see someone and I say, I think you would benefit from 12 weeks of this, that, and the other thing, and I can make a case for it, Medicare pays for it. Of course, I'm the one at risk of getting audited if I if I don't do that. But a skilled clinician can really make a good case for someone who needs the care, and it's covered, which is great.
Oh, that's
Well, this has
great.
been absolutely fascinating for me, for both of you.
Yeah.
I want to thank you for being here. And before we go, just for informational purposes, you both, Ed, you had mentioned someone could call for advice, and you as well, a service that most people might not even know exists. Can you very quickly, what's the best way for someone to reach you, Katie, if they wanted more information about your services or that part of the industry? What's the best way for
Yeah.
someone to contact you to get information?
The easiest way is probably a phone call or email. My website is www.healthyagingpt.com, and all the contact information's on there. My phone number, I can put it out in the world here, is 617-851-5315. And my email is Katie, it's Katie, @healthyagingpt.com. hdptagingpt.com. So any of those three methods, I will get back to you. Like you mentioned, I have no secretary, billing agency, or anything else. So be patient with me, but I
Talking
usually
to
get
you.
back pretty quickly.
You're on. And Ed, what about yourself?
Yeah, I mean, it's, for us, we're in Wakefield and Burlington. Probably the best way for us is either any of our social media outlets or on our website, www.hdptonline.com. All my contacts info is on there. However, whatever office you need to get in touch with, you can shoot an email usually or call us directly. Sometimes we answer Facebook messages and Instagram. I mean, anywhere that you can reach us online is fantastic, and we're very prompt in getting back to you. So.
All right. Well, there you have it. Once again, another very insightful and interesting conversation with the Chamber. I want to thank Katie Wadland from the Healthy Aging Physical Therapy and Ed Harding from HD Physical Therapy for being our guests here today. Carly, as always, thank you for being here alongside me. And hopefully you'll join us for the next episode of Conversations with the Chamber. Thank you both very much.
Thank you for
Thank you.
having me.
Thank you, guys.